Welcome to the Strengthandchiro podcast. Introducing your hosts, Doctor of Chiropractic, Stephen Redmon, and powerlifting world champion, Brogan Williams. Join us as we explore evidence-based chiropractic and sports science through the lens of movement, strength, performance, and overall health.
Come on, Redmon. Give me some gold. I've been on social media too much getting triggered, by all the pain science people.
Sounds like it.
Well, for those that are listening to this podcast, next week we have, or the following week, we have a strength coach called Bryn. And we're going to get into some real cool biomechanic chat. So I'm looking forward to that. One of the things that I've been talking to him about, and we're going to touch on as well next week, is the whole knee valgus during a squat. Do you have any opinions on that?
As long as it's not a problem, it's not a problem.
so pain, right?
Yeah, if it elicits some sort of symptoms, it's probably a problem. If it doesn't, it's probably not a problem.
Yeah, and the funny thing is, like, people tend to have pain. I mean, it can be foot, the ankle, it can be the knee itself, it can be musculature between the knee and the hip, it can be the hip, it can be the lower back, it can be the tight thoracic, it could be the shoulder. Like, you know how like force tends to distribute itself through the body. That's the thing, right? Sometimes people will have an issue and it won't necessarily be at the knee joint, but it could be at the hip, it could be at the lower back.
And sometimes people just aren't even aware of what they're doing with their body. Like, there's just a huge like homunculus disconnect.
I love the homunculus, I've got a friend at Chiro College, and his hands are like massive, and he looks like the homunculus. And so that was his nickname all through college. Oh, I feel bad. Nah, he loved it. No, the interesting thing about the knee cave, it's like this idea around it, right? Like, when you're beyond, I think it's between 45 degrees and 60 degrees of hip flexion, the adductors become quite powerful hip extensors. And so what people are saying, insert pain science crew, when you're at the bottom of the squat and you're coming up, ascending from the squat, if your knees come in, all it is your body utilizing your adductors in that hip flex position, which is another muscle to help you get out of the hole. And my position on it, and we can break this apart even further in the following weeks on the podcast, having your adductors kind of almost switch on in a sense, just for lack of a better term, you're going to see a twitch and like a little bit of, people call slight deviation. So a little bit of slight medial deviation is fine. But some of these people, the knee valgus I see, I mean, we're talking like they come out of the hole and the knees go like that. And what happens is the knees go in and shift back, which means the lumbar spine is now compromised and goes into further flexion. Of course, these people don't even think lumbar flexion is a problem under load. So they're like, it's fine. And I saw this meme, and I'll put it up in this clip if I end up posting it. And the meme's like, you thought you couldn't have knee valgus and be a world champion. And it's a picture of a female world champion at the IPF. In the lifting world, our IPF people are like the pain science people in the lifting world. They kind of mirror each other. Half of them are probably the same person. And they're saying, hey, it's fine, because like this person does it. Look at the knee, massive amount of knee valgus or, medial shift of the knee out of the hole. And they're like, look, it's fine. And those types of arguments of, hey, let's look at this example. They can be useful. They can be damaging. If you're going to do that, at least bet your chips on someone that's actually well-known and has done some shit. Get going. Because if your example is some like one-time world winner, IPF winner, who's to say they don't have hip pain? Who's to say they don't have...
Yeah, we don't know their medical history.
At all. We don't know anything, right? And people are saying, she doesn't have knee pain and she's strong. Okay, well, those are
How
two...
do we know she doesn't have knee pain?
Yeah, well...
We know she's strong.
We don't know that.
We don't know about that knee.
But when I watch really great lifters, you do see a little bit of a twitch out of the hole. My knees did do that. That's completely fine in terms of physiology, but I just love how you have all these newbies coming out of school. They've done like exercise science. Some of them might even be chiros and physios. Dr. Locke talks about like all the new grads. Like, all these new grads come out and they're all rediscovering things that we've already thought about 10 years ago, but they're discovering it and going, oh, the adductors, that's why you have knee valgus. It's completely fine. And it's like, look, like, listen up, young blood. We've known this for a long time. Like, I'm excited that you've done your first anatomy paper and you've started to figure out anatomy. Cool, 10 out of 10.
Well,
but
the thing is,
it's context.
The thing, at least in the U.S., is like that stuff's not even taught in school. Like that whole pain science paradigm, it's negligibly taught in school. So these new grads are getting their information off of social media. So they're learning from these social media gurus on what pain science is, and that's a huge issue, that there's become this pseudo-authority figure on the biopsychosocial model, and they've created their niche within it with the pain science community, and it's all just a bunch of biased people spouting information to these new grads, soon-to-be grads, that's just very different than what they heard in school, and they're like, well, this is different than what we heard in school, and this person has X amount of experience compared to maybe my professor who maybe never even was a clinician, just went through school, immediately started teaching or taught the bare minimum or worked the bare minimum and then started teaching. And so I think there's just this big disconnect with people's ability to, or clinician students' ability to recognize who is who and where biases fall and where expertise actually comes into play.
Yeah, and obviously there are a few head honchos when it comes to that, of which you've been blocked from there. how did that happen?
So on one platform it happened because I suggested that even if we just pretend and play by the MDT rules and just see what happens, with a lumbar disc herniation. So I was blocked on that because they were like, well, how can you know? And I was like, well, just try it and see. No one has to know for sure. Just try it and see what happens to the symptoms. And so that led to me being blocked on one platform. And the other one, I shared a clip or like their story or something of them like crying and telling themselves they weren't in pain while they were in pain, saying that if your clinician does this, get a new clinician.
Yeah.
Cognitive behavioral therapy is amazing and should be performed by a clinical psychologist, a mental health counselor, not by a physio, not by a chiro, not by a personal trainer. Should be done by a mental health specialist, not a musculoskeletal or performance or rehab professional. We're not trained in that at all.
Do you think that a lot of these people tend to become attracted to that ideology because a lot of them either don't understand biomechanics or they are biased, not necessarily biased, but they have a blind spot towards biomechanics because they haven't experienced it, they haven't been under the bar themselves, they don't fully understand the importance of it. Because I know when I listen to a lot of smart people that don't have any training experience, they tend to speak differently, they tend to articulate differently, they tend to miss a lot of the big picture. They are pulling from a breadth of knowledge, of academic knowledge, and maybe even clinical experience, which I respect, so it could be wrong. But without the personal experience of being under a bar or kettlebell, understanding resistance training personally, I feel like they're missing a piece of the pie, metaphorically, and that changes their perception, which then changes what they believe, and then we have these people neglecting the bio and the biopsychosocial model because they think it's not important. right? And as Dr. Locke says, technique matters. Yeah, I feel like they're coming into these arguments or these discussions, and they're almost bringing a knife to a gunfight in the sense that they don't have a full scope or full understanding of what they're talking about. Yeah, they understand the studies in the academia. Maybe they have some clinical experience, but without fully understanding what it's like to train. And that's one of the strengths I find when I listen to someone like Dr. Aaron from Squat U, or when I talk to Dr. Locke, or even myself, is that understanding. They really understand what it feels like to be under a bar. Talking about force distribution and feeling force distribution are two different things. And when you start to experience the latter, I think it kind of changes the way you process information. And possibly in a sense that could be in itself its own bias, but it doesn't change the fact once you've got that weight on your back, you can't be pissing around with some of the shit they say, some of these memes they put out. I'm just like, bro, if you had it on your back, you wouldn't be saying that. You just wouldn't. It's like half of it's common sense, And so I find that frustrating. I mean, there's just so many of them putting out snarky little comments and memes saying really disrespectful things. These guys are meant to be medical professionals. Like where's the respect? Where's the professionalism? I've seen some real disgusting stuff, real bad memes. I've reported some stuff on some of those people. Some of my friends and people I've just been speaking about, Aaron and Dr. Locke. Really disappointing to see. Really, really disappointing. But it is what it is. I think the main thing that we're trying to do with this podcast and what I'm trying to do with my platform, and I'm sure similar for you, is trying to elevate good information, trying to challenge poor information when we can, and above everything else is being people focused, right? Trying to help people move better and get out of pain. That's really what it comes down to. Like, yeah, we have student loans. Yeah, there's stresses in life. Yeah, like I've got a wife, I've got a kid, I've got a family, I've got to support. But ultimately, like, the money stuff's important, don't get me wrong. But like, ultimately, my goal is to help people. And as long as I keep that at the forefront, I feel like I'm coming from ethically a really genuine position, and that changes also how I speak on things. I don't know. That's my take on it. When you were at Chiro school, did you have many people in your class that were leaning towards that way? Because I know with Chiro, like, that can be very dogmatic. So did you have some people that were moving towards the pain side of things?
Not really. A little bit at the very end of it. So there, Craig Liebenson, he's not like a pain science zealot, but he's like a lot of people's first exposure to pain science. And in 2020, during COVID, he had this massive online free webinar series that he was doing like every Saturday for like 2 hours. And some people got exposed to it because it was free, and he had all these different speakers on. He was not at all like pushing away the biological component, the biopsychosocial model, but he was rather introducing some of the psychosocial components as well as then applying that biologically speaking. And people got introduced to it that way. And then I know some kind of went gung-ho pain science from there. But in Chiro school, to my knowledge, that's not really something that's talked about. I know it's not talked about at my school. And I know when I was an undergrad, I did this research proposal for pain science in healthcare, for looking at chiropractic schools compared to PT or physio school and med school, and just based off of the limited stuff that was available, like it's like a tiny fraction of what's taught in PT school and med school, and those are still just a fraction of it, really. There's not much information on pain science per se. It's more just like classifying pathological manifestations of pain, not really the whole gamut of what pain can be and all of that jazz.
Yeah, it's not just, yeah, exactly right. It's not just how they're talking about pain, but it's also what they're neglecting. You know, it's the biomechanical part of it that they're neglecting that's almost just as problematic, because I feel like it's easy for us to admit that pain is complicated and multifactorial, and even for certain people to act like they're an authority on the matter is very interesting, because it's very complicated and there aren't really many people that fully understand all of it. But I do like it when I see Dr. Locke introduced me to a neurosurgeon, and he's trying to push this this idea throughout Australia, that the importance of resistance training, and you know how the importance of exercise and movement, and it's really refreshing. I was watching his channel, his Instagram yesterday, and he was doing back squats and overhead press and thrusters, and it's really refreshing to see a neurosurgeon promoting that.
I don't know if I told you, but I have a newer patient, and they've been seeing a pain science-y person before they came to see me, and their complaint was like some sort of neurogenic pain in their thigh, and they couldn't touch their toes anymore, and they were always able to touch their toes until the pain started. And the person they were seeing, they told them, they were like, I can't touch my toes. I could always touch my toes up until just recently. And they're like, okay, well, we're going to help you get better, but we don't want to measure the toe touching as any kind of acknowledgement that care is going one way or the other. And that's, at that point, you've gotten lost in the pain science world, and you've lost track of patient expectations and patient's values. The patient wanted to be able to touch their toes.
Exactly.
And they ultimately came and saw me, and I was like, we're going to get you to touch your toes. And I got them to touch their toes in one visit. And they were ecstatic. And that was, it doesn't, like, your ideas regarding pain don't matter if they don't match with the patient's values and goals. Patient wanted to be able to touch their toes. So my goal was to make sure they could touch their toes in one visit, and it happened.
Well, it's 1/3 of the evidence-based triad, right? As a clinician,
Yeah.
how can you not listen to what your patient is saying to you? It's a human being in front of you. Like, taking a history, listening to what they're saying is a huge piece of the pie. How can you neglect that? Just like they neglect biomechanics. It really doesn't make much sense. Like you said, you've gotten too far. At that point, you can really tell that someone's just gotten too far into it, right? They're starting to neglect some of the most obvious things. And the thing is that person, a lot of it, like, yeah, we admit a lot of it is psychological. Like, they probably wanted you as the clinician with that power imbalance to say to them, hey, we're going to get you to touch your toes. You know, like, that's a measure of outcome that they are really attached to. And so if that's the case, then it matters to them, then it should matter to you as the doctor. And for someone to gloss over that, I feel like it's disrespectful to the patient. It's one of those things where I wonder how far it's going to progress before it begins to regress, you know, before things begin to even out. Because we're at a point now where it's like, for a patient to be almost turned away, in the sense, you know, maybe she wasn't, but that's how she felt, because she came to you saying, this is what I said, and nothing happened, and I got told this. So regardless of what else they said, they may have said and done other things, but all of that fell on deaf ears when they failed to acknowledge her chief complaint, in a sense, which sounds like what it was, right?
Yeah.
So out of interest, what well, I'm not sure if you feel comfortable talking about how you treated her, but what'd you do to help?
Well, I assessed their ability to bend forward, and it was restricted. So we did some soft tissue stuff, did some manipulation, and they got off the table, immediately able to bend down, touch their toes. And then second visit, they were still able to bend down a lot further than they were the first time before. And then adjusted them again, did some soft tissue stuff, showed them some ways to kind of create some intra-abdominal pressure, because I found out that they are doing a bunch of flexion-based things, which I think might be exacerbating it, but I don't know enough yet at the moment, but that's kind of my clinical impression right now. And they took a week off of the flexion-based exercises, and they felt okay, but then they were also in a different sleeping situation, so it's still hard to say that it was the flexion-based movements that were exacerbating it, but we know that there are nerves that come out at the mid-back running down towards the thigh, and obviously if you induce flexion, you have weight built into that, theoretically it could traction those nerves, and I'm thinking it's more like a cluneal nerve irritation, because all the disc tests were negative, and they have some pretty obvious stability issues. Like, they're not like hypermobile or anything, but they're not very stable in their spine.
So this is the thing, right? As someone that practices evidence informed as yourself, right? You listen to your patient, right? Beyond just listening to how they felt and the fact that they wanted an objective outcome of touching their toes. You did that for one, but on top of that, you educated them. You not just educated with words, but you physically educated them. And what I mean by that is you taught them how to breathe better. You taught them how to get themselves into a position that's going to help, right? You introduced a movement that's going to help. Ideally, that's going to help down-regulate the pain. You did soft tissue work. You did manipulation. Did you do manipulation? I'm guessing. So you really, multiple things you're doing here, right? Because you've got the patient's outcome, best interest at heart. And that type of integration into helping a patient is really what a doctor should do, right? Like, it makes the most sense. Everything you did is evidence-based, and the patient leaves feeling better. They have their objective outcome. And, you've got a hypothesis or an impression that you're working towards, which in itself is great, because you're not sitting here saying, oh, it's disc, or sitting here saying, oh, it's neuropathy. You're not saying it's one thing. You're saying, I have a clinical impression. We're working towards correcting it while we're helping it move better, breathe better. We're helping correct underlying dysfunction movement, and we're helping it with their pain. That is a well-rounded approach. That makes a lot of sense. Where do you think, in terms of you as a doctor, who was the most influential? What influenced you to think and perform like that? Because you yourself are only, how long are you? You're only half a year practice out of college? A year?
I'm
almost a year.
Almost a year into practice. It'll be 2 months.
So you've been out for almost a year, and you're already practicing that way when many fail to do so. And I mean, I don't want to put anyone on blast, but a friend just recently told me, I was helping the friend out with some treatment, and while they were unable to see me, they went to an osteo. And again, I'm not going to sit here and name anything, but what the osteo literally just adjusted the upper back and said, you'll be fine in 2 weeks. I understand the history, I understand everything that's going on. That wasn't my approach. I was just shocked for her to say that. This person's been in practice for 40 years, and they're doing that. So how come someone that's a year out of college can be taking all these different interventions to help their patients? What influenced you to get to that point?
Well, what influenced me was the fact that I did not receive good care, so I have that traumatic spondy, and I went through the whole gamut of healthcare, and I got little pieces of the puzzle put together through various clinicians. A little bit of things I liked, a little bit of things I didn't like. Lots of things missed, lots of things just not done, and it just delayed everything. And so I tried to combined as many things as possible. So typically, like, we think of like a physio, and you're only going to see them and get some sort of rehab therapy done. Typically, you're going to go see a chiropractor, and you're only going to get manipulation done, maybe a little bit of soft tissue. And I don't want to be one or the other. Like, I'm going to combine everything that I'm able to do, everything that I'm knowledgeable enough to do. So there's going to be some manipulation. It's going to be some soft tissue. It's going to be some rehab. It's going to be some lifestyle changes. It's going to be some neurological motor control type things. Like, those are the things that we should be doing. And if you look at the education model for a chiropractor, it's all the things that you're required to know to be an entry-level provider according to the U.S. National Board certification people, NBCE people. Like, those are the things they test us on. So why are we not doing that in practice? I don't know. I mean, sure, some of the things that they do test us on is like 10, 15 years out of date, but it's still in that direction that a lot of chiros are just like, yeah, I'm not going to do that. And I don't really understand why they see that we learn these things, and then they're like, but we learned it just for the board exam. No, you learned it to prove that you're competent as an entry-level provider, not to pass a board. You learned it because it's what is expected according to the national board.
Makes sense. But like, how do you? I'm not sure what it's like for you, but I know here in New Zealand, definitely not enough training goes into, or education goes into biomechanics. Not enough education goes into understanding how someone moves, right? So like applied physiology to anatomy and actually understanding how you can help someone. We had one rehab paper, and within that rehab paper, it was learning about modalities. What I mean by that is it was learning about cupping. It was learning about trigger points, which is an overwhelming amount of research saying that the trigger points aren't even a thing. But I digress. Like, there just wasn't enough. There's one biomechanics paper, one rehab paper, and that is not enough. It's not even close. Just not even close. And I said to my friend the other day, I said, I feel sorry for you in the sense that you have to get to the end of chiro college, graduate, and then go back to the start in many ways and learn things from the start. So whether that's different between schools and that's different for you and your education, I know you were a manual therapist, a massage therapist prior to that. You also got experience training. We've actually never spoken about this. Like, this is the first time we'll be talking about it on air. What is your experience with training? Because I know you've got some experience with training. I know you've been into skating your whole life. From what I know, you love skating. So you've always been moving, and that's a big part of your life. But obviously that's impacted how you practice. So yeah, give me a little bit of an insight into that.
Yeah, I'm absolutely not like a personal trainer or a strength coach. I do have a degree in exercise science, and I use that knowledge to help people. And I've definitely given people exercise prescription based off of what I learned in my exercise science program, coupled with what I understand about medical conditions as a chiropractor. And I've really only like truly trained one person. Like, hey, these are your goals. We're going to get you from here to here, and let's introduce these types of goals as well, because these are even better goals that are going to objectively make you happier than what your initial goals are. And I had really good results with that, and that was a long time ago. And I mean, for the most part, once you understand what the client's goals are and you understand how to modify exercise, regress, progress, and how to measure strength, how to measure 1 rep max, how to make sure they're not going too far with their RPEs. And that stuff is probably not taught in any chiro school unless you're doing like a master's in exercise science.
So that's the
or
difference.
Sports chiropractic.
That's why a year out of school you're
Yeah.
practicing like that, because you've done a full exercise science degree, which most chiropractors, I would say, have not. So what do you...
Yeah. Or if they did, they kind of slept through it. Because I have an exercise science degree, but I got an exercise science degree as a massage therapist. So I was already looking at everything differently than most of my peers in school. Because they were like looking at it like, I should get this grade in this class so I can apply to PT school, physio school, or med school, or nursing school, or whatever. And I'm like, I see people every day with these types of complaints based off of these exercises that they're doing. So I want to learn as much as I can about why they're doing these exercises. Should they be doing these exercises? Should they be modifying these exercises? As well as all like the nutritional aspects as well.
I like what you're saying. What would you suggest for someone coming out of chiropractic? Because, again, I'm not going to name names, but there are a lot of people that we both know that just go and do like an online cert after chiro college, and then they put a few letters after their name, and boom, I'm an exercise specialist, or I'm a rehab specialist, and now I'm equipped to be treating everyone this way or this way or this way. What are your thoughts on that, and what are your thoughts on alternatives in terms of education for people once they graduate? Primarily as chiropractors, but this could be the same for anyone, I suppose.
Online education is great for knowledge. It's going to help it's going to fill in gaps that you didn't already, gaps in knowledge that you didn't have before, and make you a more well-rounded clinician. But it doesn't truly make you like a strength coach or a performance expert or a nutritionist. It just fills in some of those gaps so you can better communicate things and better understand when to refer out. It's like I'm not a trainer. I'm not a strength coach. I'm not gonna sit there and work with a patient through those types of goals. I will send them somewhere else. But I will go and I will structure my rehab based off of those training methodologies, but with a clinician's mindset, being mindful of what they can and cannot do based off of what's going on with their body. And so I think it's great that there are a lot of new grads going out there and getting all these online certs and things, but at the end of the day, if you're trying to wear 50 hats at once, you're never going to be where you want to be. I know NPI, they like to say, get really, really good at one thing, like own one thing, then get really, really good at two things, and then know a lot of other things. So just really hone in on three things. Absolutely own the first one, be amazingly good, probably one of the best people in your area at the others, and then just know a bunch of other things. And that's where a referral network comes in, and you just send people to those to get help for those other things, and you're knowledgeable enough to be able to communicate with that patient about.
Yeah, I really like that idea around becoming an expert, because I know when we come from different backgrounds, obviously, but how we both practice is ultimately going to land in a very similar manner once I open my clinic, that is. But what I'm saying is I come from a strength and conditioning background. I've worked with military, I've worked with police, I've helped cops do armed defenders, which is our SWAT. I've helped people win comps, be powerlifting champions, all types of people, girls, guys, older, younger. Like, the principles I've applied I've been able to make people better across the board with the same principles, which is the amazing thing about strength and conditioning, right? You have to make adjustments per person, but the overarching principles that govern physiology and movement are often the same. And when you become an expert in that really helps you clinically. And that's the thing, like you're saying, you can't do everything. And for me, that's been the shift. It's been the shift from trying to take off my strength and conditioning coach hat so that I can put on a clinician hat, you know, or trying to put a research hat. Like the season I've been in at the moment with all doing research, it's a new hat, you know. Ultimately, I want to be a clinician. I don't necessarily want to be a strength coach or a researcher. But they're all pit stops along the way that make me better when it comes to dealing with a patient, because I have that knowledge. You know, I have that knowledge of education or academia, so that you know how to prescribe things, or you know what's happening, or having that knowledge of strength and conditioning so that you know how to help someone move better, or you know how to not only educate them verbally, but put them into positions where they feel better, that they can actually get out of pain and correct underlying mechanisms that aren't working properly. So I love that idea about getting really good at one thing, getting really, really good at it, and then the third thing, and then getting, you know, knowing a lot of fourth, fifth, and sixth, and seventh, and eighth things. It's funny you say that, because, right, like I have this here, and you're probably a bit well aware of that. Is that something you've looked at a lot yourself?
Yeah, that's a really good manual that.
Yeah, so for the people that aren't watching or couldn't see it, it's called Condensed Case Management for Chiropractors. Mark and Steve King. Are they brothers? Yeah. And it's fantastic.
Yes,
it's not meant to teach you every little thing about everything. It's just cliff notes of some of the main things you're going to see as a chiro or a manual medicine doc. And I put this together myself. I've done the online spine and the extremity and the upper and lower vision things while I was a chiropractic student. I did all that, and I did this all myself. So I think I've sent it to you, and anyone that's listening, if you want it, I'm more than happy to. If you've bought the program, I'm more than happy to send it for free. I don't think I should be sending it to random people, because it's not intellectual property. But if you've bought the program, I'm more than happy to send it to you, because that's really, for me, is I found the information on the programs was absolutely next to none, amazing, but I couldn't take it from that to the patient in practice because it was on my computer in a video form. So it's just all in here in Cliff Notes. All the best adjustments. It's fantastic. But yeah, MPI, the way MPI thinks, when I was a chiropractic student, that was like what really saved me, like kept me going as a student. It wasn't enough, because I've left the profession. I don't want to be a chiropractor. I don't want to be associated with the chiropractic profession, because like in my country, it's just so dogmatic. It's just not beneficial for me to do so. But it would be a different question if I lived in America and I was able to like actually hang out and spend time with people like yourself, who were so like-minded. But there are amazing chiropractors out there like yourself. The MPI people seem to really be the cutting edge. Like, I love it. To me, that's like the best part of chiropractic. Unfortunately, we have zero MPI in New Zealand, so it's just no way to progress it in this country, which is sad. But anyway, leading on from that, I did want to talk about things that I've been looking into lately, and I think I may have put it up with you. Oh, before I do that, I got this little nifty thing. It's just one for the hand. I don't know if you've seen like just the hand ones, because I've got a big one, but often the big one, the minute you put the big one on the neck, it shakes your cerebellum like crazy, and you can't see. Like, yeah. So like, I was finding I couldn't use it at all, and so I got a little one. And the cool thing about this is it's pressure sensitive, so you put it on one, it's a real soft, gentle. You can put it on the neck, it's fine. And then if you need to go a little harder, as you increase the pressure, it goes faster. So it's really, really nifty. And then even if you don't want to turn it on, you can just use it as like I'm sure you're well aware of those, those massage tools that look like this like analog, like a wood stick. And so sometimes I even just use it like that, because I'm quite a strong guy, and I can just put my palm up like that. And so it's a really fantastic little tool, especially if I'm mobilizing, doing like a mobilization, and like rather than using like an activator with an immobilizing technique, say with the cervical, using mobilizing adding the massage, the kind of deep tissue stuff with it. It seems they've really good results from that. Anyway, so what I was going to say is the SI joint. We were briefly talking about it a few weeks ago. You may have even forgotten. I was talking to you about what you're looking for when you're palpating the SI joint. And I can remember back to what Corey Campbell, I remember he was saying it's block of wood versus a block of cheese. Right? And that makes a lot of sense because you guys are not under any illusion that you can feel these massive gross movements in the SI joint, right? We understand that when someone is going through gait, or then when we're going into unilateral stance, or we're doing a marching test, you know, like the classic like marching test or like a Lay's test. The locking system of the circular joint really makes it very hard to feel movement, and so people often say like, "Hey, palpation is very not very reliable." But I do like that kind of analogy of wood versus cheese. I am interested to know your thoughts on that because I've recently been reading some studies, and there's a bunch of really interesting studies here. I can read out just a couple of words from them, but the self-locking mechanism that goes into effect when the pelvis is loaded in a one-leg standing position probably obstructs the movement in the sacroiliac joint. Therefore, the standing hip flexion test cannot be recommended as a diagnostic tool for evaluating joint motion. That's one of them. Very small movements were registered in the sacroiliac joint. So this is just a bunch of different studies. Small movements were detected. One is looking at the Chamberlain examination. One is looking at the Chile's. We're talking like 0.8 degrees of 0.3 degrees of rotation on certain studies. The SI joint just, all the research shows, just does not move much. So why are people out there? Why are we being taught in college and being told that we can feel these gross movements through the fat pad of our thenar, through the muscle, through the bone? You know what I'm saying? Like, we've got all this stuff happening, and then half the time we're on, pants or a gown and cloth and cotton, and then you've got their musculature and their, going through their almost like a glute area. Are we feeling it? Are we not? What's your point? What's your opinion?
There's so minimal movement in the SI joint. It's more just probably assessing the way the firing pattern works for the hip and the leg based off of the movement of the SI joint. I tell my students all the time when we were going over some biomechanics of the SI joint months ago that movement there, it's not much. So you have to have full hip flexion, full hip extension to even have true SI joint movement. If you're not going through that full movement of hip flexion and extension, there's probably going to be
because of the locking mechanism, right?
Movement of the SI joint. It's not like, if you look at all the ligaments that make up the pelvis, it's impossible for there to be any of that movement. There may be some gliding patterns, like minuscule gliding, and that's probably what MPI is getting at with their kind of motion analysis palpation of the pelvis. That's definitely my takeaway for it. That's how I'm doing it. I'm not, so with the block wood versus block of cheese, it's not like somewhere else in the spine where you're looking for like some pretty exaggerated movement or lack of movement. Like with the SI joint in particular, looking at the upper boot, the lower boot, if you want to be that specific, we're just looking to see if there's any movement at all. And there should be some subtle movement, but most of the time you're probably just going to be imagining it anyways because it is so subtle that
it could be, look at the variables.
Not a make or break. And that's why a lot of chiropractors give results with like the blocking of the pelvis as opposed to the manual manipulation of the pelvis. Because when you look at it as a locking mechanism, there's not much movement, but sure, if you move gravity a little bit, you'll get some movement. some gapping of the joints the same as if you're going to manually manipulate it with your hands.
Once again, we come back to these neurological modulated effects that we're getting from these manual movements. We think we're putting back into, not us, but dogmatically thinking we're putting things back into place, but really it's all just modulated through the neurological system. And the funny thing with the SI joint is, you know, people love to act like they're being specific and that they are superior to other people in their treatment because they're feeling that their SI joint is moving 0.1 degrees when they've got someone when they're palpating or doing something like that. And it's likely that they're just full of shit and they're not feeling anything. Or they look at the variables here, like the of the muscles, pliability of the fascia, the skin, hydration, have they been drinking enough water? Like, it all does change how you feel things. So there are variables at play that change how you're perceiving what you're feeling, and you're going, oh, this is hard, or this is not moving, and then you go and whack on a side posture. Another thing I wanted to ask you about directly in line with what we're talking about is, I mean, how accurate are these? Do these side postures even need to be? Because in chiro school, we're taught, hey, it goes PI, or it goes AS, or it goes IN, or it goes EX, and then we're taught about SI nutation and counter nutation. We talk about a posterior sacrum. We're talking about an AI sacrum, right? And ways that we can go in there and that we can specifically contact it and push it back into place. We know that's not true. That's not the reality. So if an adjustment is a neurologically modulated intervention, why are we adjusting the SI joint in the first place? And I know before you said, hey, it's got to do with other things. Interesting. That's true. But if that was the case, wouldn't we be better doing some type of hands-on education thing around core stability or integration of hip flexion and lower back, you know, or intra-abdominal pressure or movement or bracing or something like that can help them move better? If we're looking at fascia oblique slings, if we're looking at tension and tightness through these systems in the body, not necessarily about a place, why is the side posture adjustment so commonly used for SI?
So a side posture adjustment can be a very quick modulator, whereas the other ones are going to take time.
Yeah.
And that doesn't mean you shouldn't do those, but it does take time, and that can decrease patient buy-in. It can also delay patient outcomes if you're going to refuse to do it. But you can, as long as there's no red flags, you can absolutely do it to create an instant change, and then you can add in the extra stuff and help them understand why.
How specific does it have to be? The reality of the specificity is, like, if something's not moving great, get them on the side and give them a side posture, and like you said, you're going to get a immediate neurologically modulated effect. But surely you'd have to follow that up with something that's going to cement those changes more long term, which would be the movement based stuff, right? So with the SI specifically, why check 6 points once? And why have multiple SI adjustments? Like with the MPI stuff, they have like all these different, like, why not just get them on the side and just set it, like, just freaking send it?
Yeah, the way the MPI, they do it, they're looking for certain motions that are
6 degrees, right?
Not moving, and they try to help facilitate that directional
but
movement.
like with research shows that you can knock on it anyway and it's going to help it move better.
So,
my only question with the MPI stuff, I get they're trying to be specific, but does it really require specificity at that level?
I wouldn't say that they're trying to overly be specific. The biggest thing is they try to separate mutation from counter mutation, and then the SI joint, they just kind of do whatever they want. And I don't know that I necessarily agree with the mutation versus counter mutation idea, like, because it doesn't move. Like, the lumbosacral junction does not move. I mean, mine moves because it's
You've got a spondy.
Mechanically unstable. It's not attached. So mine does move, but most people's do not move. So the fact that you want to contact the apex versus the base of the sacrum, I don't
Yeah, that's what I was getting
really
at.
clinically care about that. If it allows you to create a better lever for yourself, that's great.
That's
But
what I
other
was
than
getting
that,
at, really. It just sounds like a
I
Gonstead
don't
thing,
see.
like specifically, like trying to like push the apex in a certain position because you feel like it's a mutated or kind of mutated restriction. Sounds like almost like Gonstead. Like that's one thing I was when I heard it from MPI, I was just surprised about. No hate, obviously. I think MPI is fantastic. Did you see my post about Gonstead?
I've not
You've
been
been busy.
on social media that much lately.
I put this up on my story and I was expecting a massive amount of backlash, but I can't believe how much support I had. You know, like lots of chiropractors hitting me up saying they agree. And that's actually really cool to hear. Because like I said, I'm not just about elevating good information, but when the time serves, I'm about challenging bad information, and I don't want my people to be negative. But from time to time, I feel like our podcast and our platforms should be used to try and sometimes some of the old stuff. And you're probably you probably agree with all of it because a lot of the stuff we've spoken about, really surprising. But for those that haven't seen it, you can go to it was a story, so it's not up on my Instagram anymore. But pretty much the main points. I also said on the next story, on the one you wouldn't have written that, but on the next story I said if anyone wants all the references to message me, and I ended up sending like 20 Word documents to people who wanted to read what I've got there. And like real quick for just the listeners that are here, number one, adjustments can't be specific, and cavitations can occur up to 14 centimeters from the target vertebra, and that's based on some of the MIG stuff and some of those studies. I've got all the studies on a Word document, and they're also on this. The next thing, obviously, was the frictionless interface between the skin, fascia, and the bone. I just feel like people go way over the top with tissue pulls. The whole tissue pull thing it's just like, if it makes you feel comfortable in how you adjust, that's fine. Go for it. I'm not going to adjust. But for it to be the inclusion criteria for how to adjust well, that's just not true. They've got some studies here showing how force interacts with the spine in terms of gapping the facet and not moving a bone back on a disc. That's not how it works. It's not biomechanically accurate. Number 4 is a quote from Heidi Havoc, who works here in New Zealand, and that's pretty much just talking about how chiropractic care is moving closer towards modulating in the brain, neurological modulation, versus the bone out of place model being wrong. Number 5 would be X-rays shouldn't be taken for postural analysis or reasons or subluxation reasons. And there's been multiple reviews, but there's a 2008 narrative review that just strong evidence demonstrates a risk of imaging such as excessive radiation exposure, overdiagnosis, subsequent low-value investigation and treatment procedures, and increased costs. And then the last one is just you can't be accurate with position, so why do postural assessments with X-rays? And there's more studies on that showing primarily the pelvic tilt. It's almost impossible based on the day. Someone comes in and they shoot an X-ray and they might have muscle spasm, they might not, they might be dehydrated, they might have trained back the day before, they might have done unilateral squats, split squats the day before, they might have stepped wrong, they might have hurt themselves, and the positioning of your X-ray is going to be different. Then you take drawing all these postural lines, and then you're telling yourself through this inclusion bias that you are seeing a PI or an AS, and then that completely impacts how you treat the patient. And that's what I ran into when I was an intern, wanting to treat my patient one way, being told by the mentor that I had to go off X-rays that are 3 years old. That feeling that one thing, and they're telling me that I have to adjust another thing, which is not there in real life because of a superimposed 2D image. So I know that's a lot of information, but any thoughts to add to that?
Good stuff.
Brilliant. Well, hey, we've clocked over an hour. So I really enjoyed having Dr. Mike on the last episode. This is a really good platform to have those discussions. And I had heaps of feedback. We had thousands of views across all of the platforms, like heaps of views, lots of engagement. And I've been getting a lot of emails from people who are in chiro school or in physio schools saying that our content is challenging them in a good way. So that's honest, that's like we said before, that's the goal of why we're doing this, is to elevate good information, occasionally challenge the bad, but we don't want to be negative. We want to be positive, and then, it's patient outcomes at the end of the day. We want to don't work hard, and I think we've got another podcast in the next week or two with Bryn and Luke, which I'm looking forward to. Any final words from you, Doctor?
No final words.
All right, man. Have a good one.
Later.
See you later.
And Chiro podcast. Introducing your hosts, Doctor of Chiropractic, Stephen Redmon, and powerlifting world champion, Brogan Williams. Join us as we explore evidence-based chiropractic and sports science through the lens of movement, strength, performance, and overall health.